Cardiologists here. The first one is Frank Pantridge. In 1916, October the 3rd, developed the first defibrillator. After figuring out that most of the people that were picked up after a heart attack and died within the first hour, and was usually from BFib. So, first defibrillator. William Gorgas introduced mosquito control to prevent yellow fever and malaria. Sir Patrick Manson, Scottish physician and parasitologist, was born. He's been called the father of tropical medicine. So, a big day, actually a bigger day for ID than for cardiology. And unfortunately, we couldn't find anything pulmonary. Sorry. Also, another announcement. Congratulations to Dr. Aruni Bhatnagar. I'm sure that most of you guys saw the announcement, at least in the newspaper. If not on U of L Today. He is the lead investigator on a couple of multi-million-dollar NIH grants for developing and implementing regulatory policy for tobacco products for the FDA. This is a very exciting type of research and type of project to be doing. And again, I think we should all congratulate Aruni on really quite a spectacular achievement in getting these awards. So for today then, it's my pleasure to introduce Dr. Tanya Wiese. Dr. Wiese is a Michigan woman all the way, from her undergraduate years in Ann Arbor and culminating in her pulmonary critical care fellowship at Henry Ford Hospital. After a stint in the armed services and a stint in a private practice setting, the University of Louisville was successful in recruiting her here to become the head of their interventional pulmonology program. In her role thus far, she's been able to obtain funding to develop this program. She has developed a curriculum for her fellows in this field, and has initiated and taken part in a number of the clinical enterprises, including the Pulmonary Nodule Clinic over at the Brown Cancer Center. So this sounds like a very exciting field. I know that I'm looking forward to hearing it. So without further ado, I'll welcome Tanya to the stage to talk about adventures in bronchoscopy.
Okay, thanks. So my goal today is to basically present a little bit of an overview of what IP is. We still have a lot of doctors asking us, what exactly does an IP physician do? What can you offer my patients? So I'm not going to dive into any of these topics in too much detail. Most of them will require an hour or more just to talk about. So we're just going to go over a little bit of each of the different topics just so you can get a better idea of what we can do for you. So interventional pulmonary is similar to interventional cardiology. You have the pulmonologists who don't do this and the ones who do the interventional stuff, same as the cardiologist. The goal is that in 2017 we're going to have a ACGM accredited fellowship. Right now there's about 20 programs in the country, including Canada, and it's an additional 1 year of training, and we train basically therapeutic diagnostic techniques to diagnose airway disorders and pleural disorders. So just a little history on the left here. This is Dr. Killiam. He was the founder of what we call interventional pulmonology. You can see they used to bronch people awake in the chair. Even when we developed the flexible, a lot of people started off bronching people awake in the chairs. He first used the rigid scope to take out foreign bodies, and then when diphtheria hit, they used it a lot to break up the webbing that you get in the trachea. This is what the rigid bronchoscope looks like today. We usually do all our patients paralyzed, all of them are sedated. This is Dr. Akita. He's the one who developed in 1968 the flexible bronchoscope. Back then, some of the older doctors, you remember, we just looked through the eyepiece. Now we have new flexible bronchoscopes with high definition video capability. They have 3mm working channels, so you can fit large instruments into it. And now they even come, if you see this little knob here, where you can rotate the end of it. So this will rotate 120 degrees so that you can get into the more difficult locations with it. And this was in 1897. This was in 1968. So between that time, slow progress, but now it's starting to finally take off. This is not an all-inclusive list, but this is some of the things that we offer, and I'm going to just briefly go over some of the more common ones so you guys can have a better idea. I think a lot of times when people look at IP doctors, they think more of that means we can do a rigid, but it's a little bit more than that. 15 years ago, most people looked at us as palliative type doctors. You know, somebody had a large obstruction in the airway, you're trying to get them off the vent or get them home with hospice, and they had consult us to come scoop the tumor out, put a stent in. But today, with the advances in technology, we've moved more towards the early diagnosis and treatment. So this was just this year in April in Life Science, talking about how the pulmonary market for technology took up approximately 10% of the market in 2009. They're projected to go up to 56% by the year 2015. And most of that is going to be in the interventional field. In 2007, we were projected to mirror the growth of cardiology at one time, up to, in 2011, $3.8 billion of the market. And you can see they just came out with the numbers, and we hit the $3 billion mark. So a lot of progress in this area. It's really taking off. You know, we used to get all our equipment from the GI people, and now we're actually having some of our equipment developed for us. So I'm going to start with the rigid bronchoscopy. This is what it looks like. These are the different types of instruments you can put through it. So it's mainly used to debulk large tumors in the airway. You get much larger forceps over here that you could take large pieces out at one time. You can also use it to remove large objects, so foreign bodies or large bronchial lists that you wouldn't be able to pull through the vocal cords. And then we use it commonly to place removable stents, so the silicone stents. This is just a little video clip what it looks like to intubate somebody with a rigid scope. Obviously, our limitation is going to be somebody who can't bend their neck. You got to have the neck bent really far so you can get this, you know, it's like a pipe. It has a beveled end on it. You use that to lift up the epiglottis, and then you have to turn it so you don't damage the vocal cords or the arytenoids. So pretty easy in most patients if they are able to open up their mouth wide, and if you're able to get them to bend their neck. This is part of the reason why they're usually paralyzed when we do this, as well as sedated. And unfortunately, this video clip for some reason is not working. This is one of the ways that we can remove a large tumor in one setting. Instead of spending maybe a half an hour to an hour lasering it, you do what's called the apple core technique, and you use the bevel of the rigid scope, and you twist it into the tumor and pull the whole tumor into your scope. At the same time that scope's tamponading the bleeding, you pull the tumor out, and then you can laser as you're coming out. Unfortunately, that one's not working. The lasers that we use commonly in the airway to debulk the tumor or vaporize the tumor is the YAG laser. Because of its properties, it's pretty good with tumors and stenosis. And it can penetrate approximately a centimeter below the tissue. The holmium laser we also use, similar to what the urologists use to break up stones. We use it to break up the bronchiolists. Basically, it heats up the stone, the water in the stone, and the water expands, and then it fractures the stone. We're fortunate enough, we have both these at the university with a combo YAG holmium laser. The laser has also been shown in studies that we can also use this to treat early stage lung cancer. Right now, just central. The technology is still pending as far as peripheral treatment. This is basically what the laser will look like. Oh. So this is a 40 watts to vaporize the tumor, which is different than electrocautery. With electrocautery, you're just going to form an eschar there, and it won't penetrate beyond that. With this, you can just keep lasering it, and it'll eventually vaporize it. You can also use it to get it to just stop bleeding so you can debulk it. You can also use the laser for other things. At 100 watts, you can use it if you need to fracture metal in the airway. So a lot of the wall stents that were put in a few years ago, actually more than that now, probably a decade ago, would fracture, and then these pieces of metal would hang into the airway and cause granulation tissue. With 100 watts, you can see you can just fracture that instead of trying to tear it off the wall and take metal out. The laser, we usually use the rule of 4. It's non-contact. You pulse it at 0.4 seconds at 40 watts. You need to keep the FiO2 obviously low as you can. Less than 40% is usually the safest, so you don't start a fire. And then you want to keep it away from anything that's flammable, like a stent, your suction catheter, or the endotracheal tube. It's important to know that even though they say they're putting a laser-safe endotracheal tube in there, it can still catch on fire. So you want to stay at least 4 centimeters away from that. And then we get consults a lot for people who've had a collapsed lung. You get a CAT scan, actually the lung's been collapsed for weeks and weeks, and they're just now coming to you. You got to be careful. Not everyone is, even if you re-expand that, is going to have perfusion back. So they may have already cut off perfusion. So most people look at the cutoff around 4 weeks. Studies show obviously most people get some kind of relief of their shortness of breath, but when you compare it to radiation alone, you almost double the days of survival. And at 7 months, 64% were alive compared to 0% in the control group, which just got the radiation. So it does play an additional role to the chemo and radiation. Electrocautery, same indications as laser. We call this the poor man's laser. And the reason is because it's a lot safer, but it doesn't vaporize the tissue. That's the big difference. So it's going to be very slow if you're using it to do a lot of tissue debulking. I mainly use it to cauterize or to get it to bleed, not bleed, and then debulk it with something else. If you're using it to try to debulk, you have to remove the eschar every time you do it and then redo it. The nice thing is it comes in, you can have it in a probe, forceps, snares. You can snare the polyps just like they do in the colon. Or you can shoot it out in the form of a beam with argon gas. So a lot of people confuse that with laser. They're a lot different, and I think I have a video clip here of what it looks like. The other thing about this is if the patient's moving a lot, the beam will tend to go towards your target, so you don't have to have the best aim. There aren't any controlled studies on this, but the success rate you can see is 70-90%, so it's still very good to use. And it can also be used to treat early stage lung cancer, so carcinoma in situ, but not very deep. It only goes about 5 millimeters. Cryotherapy, some people do use this for tumor debulking. I don't. It's very slow. You freeze, you pull tissue off, you freeze, you let it necrose, and it sloughs off, and you got to do multiple bronchs. I think it's better used for hemostasis and removing foreign bodies or removing large clots or bronchial cast, things like that. It can also be used to treat early stage cancer. It's been better studied than electrocautery. So if you know that the patient has carcinoma in situ, you can use it for that. And then you've probably seen in the literature, there's a lot of new stuff right now on using it for biopsying peripheral lesions with interstitial lung disease to get the diagnosis, or in lung transplant patients to look for rejection. They've also developed a cryoneedle now that's supposed to be better for FNAs. This is just a picture here of how you can freeze and extract large clots, treat small tumors or carcinoma in situ. But comparing here the cryobiopsies, you can see with a regular conventional forceps, you get about 2 millimeter bites compared to 5 to 10 millimeter bites with the cryobiopsy. And it actually is just as safe because you're freezing, you're not getting the bleeding you'd expect, and you're really not increasing your risk of pneumothorax as long as you're staying away from the pleura. For the central airways, using it for endobronchial biopsies, I think people forget. They always use the conventional forceps, which you may have more bleeding, or you may just get the outside, not get deep into the tissue and get the diagnosis. This increases your yield from about 85% to 95%. The lymph nodes, the data for this is still out, but I think it's going to be promising. For peripheral, there's studies ongoing right now looking at cryotherapy. Once you're in there, you've diagnosed them with cancer from your biopsy, to go ahead and at that time treat them if it's a early stage. And then the most recent study shown in lung transplant patients and in patients with diffuse interstitial lung disease, improvement in your diagnostic yield. For the transplant patients, you can see you increased your size from 2 millimeters to 10 millimeters, and you got more of the tissue that the pathologist is looking for, and you decreased your time with fluoro. Stents, not my favorite topic because we don't have a good stent right now. Our stents have a lot of problems, so I try to limit my stents to patients who I don't think have a long prognosis or curable disease. But they can be used for benign disorders. It's just that they have so many problems. The indications vary to extrinsic compression, malacia after removing tumor, or even people have focal malacia or excessive dynamic airway collapse, although I don't think it works very well for that. But if they're a benign condition, you're going to be putting in a removable stent anyways, you can always take it out. You can also use it to cover up fistulas or to help with after lung transplant with the strictures. It used to be we just had either the removable, which was the silicone, or the metal. The metal could be covered or uncovered. But now we have the hybrid stents, which are very nice. I'm going to show you a picture of those. The main complications you're going to see are granulation tissue formation, which is the major problem. So in somebody with a benign condition, you're putting them a stent in, and you may actually be worsening their airways if they develop this granulation tissue. Migration, patients can cough them out, or they can move. Usually they migrate distally, though, and then they end up causing granulation tissue because they're in the wrong area. They can become infected, they can fracture like I showed you, and then you got metal hanging in the airway. And then we're limited with our size. We get a lot of consults for stenting, especially in the upper airways, and we don't really have good sized stents to fit those. So our stents mainly right now are limited to the trachea and the main stems, occasionally the right middle lobe. Almost all the studies, of course, show improvement in shortness of air and quality of life. This is what the removable ones look like. These happen to be Wiese stents. So if you have disease at the carina or that involves the carina, these are removable. Depending on which type you're using, can be pretty easy to put in or really hard, especially if you're doing the dynamic Wiese stents. This is what the metal stents look like, both covered and uncovered. Uncovered are not used that much. Obviously, you get tissue growth in there. And then this is what the new hybrid stents look like. Right now, this is the only one I know of on the market. But you have it completely covered now with silicone, but you still have a little purse string here that if you need to remove them, you can. And if you do it within the first few months, they're pretty easy to get out. After that, usually they become embedded with granulation tissue and become very hard to remove. This is one of the older covered stents. Even though this one's being placed with a rigid, you don't really need to place it with a rigid. We probably were doing tumor debulking, and we had them under the rigid anyways. But normally you can just put this over a guide wire and put it in. These ones were temporarily taken off the market. Now they're back on. But these are probably the easiest to place. The new hybrid stents are a little bit bigger, and even though they say you can place them under conscious sedation, are a little bit more difficult to do that. And over time, even though it doesn't look like it's fitting in the airway, this is going to continue to expand and get bigger. And these are just some of the complications you can see. This one migrated. It was supposed to be a stent where they had stenosis at the anastomosis after lung transplant, but it's slipped past that. This is what they look like when they become occluded with secretions, they become infected, or they tear. And this is probably the most common. They slip, they move, or even in the right position, and they'll start forming this granulation tissue. So maybe this person had a stenosis up here more proximal. Now you're going to have somebody who's got stenosis down here, and you've lost more of their airway. So they can do a lot of damage. We still don't have a good stent. Balloon dilation. It's never really recommended that you're doing balloon dilation alone. Usually you're using it to help you open a stent, help you open stenosis. This is, if the stent's not opening, you can put it in there and sort of pop it open that way. After you've lasered a little bit and you want to see where your diameter is on the opposite side, you can sort of balloon it open here. I don't know if this is a video. You can see, so you can see past it. Oop. It's not. The narrowband imaging. So we used to talk about autofluorescence for diagnosing early stage cancer, basically using blue light instead of white light to increase your diagnostic yields of finding carcinoma in situ. Now we use narrowband imaging, so instead of just blue light, we're using blue and green light, so then you can penetrate below the mucosal surface, and then you can see the blood vessels. So it had the same sensitivity as AFB, but it increased its specificity. So the problem with autofluorescence is if you bumped into the wall or you caused some bleeding or a suction mark, it may look like something abnormal. But with the narrowband imaging, it's much easier to tell if it's cancer or not. So it increases your diagnostic yield compared to white light by 20%. And this is what it looks like. It's a little hard to tell in this light, but basically it'll look green, and then you can see the vessels. Here you see a bunch of dotting. Under white light you couldn't see that, and that's indicative of probably a cancer. You can biopsy that and show whether it is. Here you can see where the vessels have gotten very large in caliber. They have abrupt endings, or they're starting to loop and get all messy. That's also probably cancer. There's no studies in the United States. There's been some studies looking at using narrowband imaging as a screening tool. Right now we usually use it as a tool to help us with treatment. So if I'm going to do brachytherapy or PDT, I know where I'm going to go and target the laser or the brachytherapy. So the other thing is radial EBUS I wanted to talk about. Everyone hears EBUS, 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 and they're usually talking about curvilinear EBUS. So we're using it to help us do FNAs of the lymph nodes. But radial EBUS is very important to us. You can use a balloon EBUS and look at actually the layers of the airway wall. If the tumor is penetrated past the cartilaginous ring, then it's no longer considered carcinoma in situ. So before you say something's carcinoma in situ and I'm going to cure them with, PDT, brachytherapy, or laser or cryo, you have to prove that. And so you can use the radial probe, and I'll show you an example of that. And then also we can use the ultra mini, which is really small, to confirm our position before we biopsy a solitary lymph node. This is what they look at. This is the radial EBUS balloon that you can look at the airway walls. And then this is the ultra mini. It's small as, just a little bit bigger than the tip of your pen, and that can go way out to the periphery. So this is what the balloon EBUS images will look like. So you can see the anatomical specimen here. The important part here is to see the hyperechoic part around here. That's the cartilaginous ring. If the tumor is penetrated past that, it's no longer carcinoma in situ. And here's a good example. You can see the tumor here growing in, and it's totally destroyed the cartilage. So this would not be a person you can say, okay, I'm going to cure your cancer with doing the laser or the cryo. So some of the features that you'll see if you're looking at this with the ultra mini and a peripheral solitary pulmonary nodule that you're going to be looking for is continuous hyperechoic margin, absence of linear discrete air bronchiograms, and the heterogeneity. So here you have an example. You can see it's very these discrete linear arcs going out. If you take the probe and you're moving it in slowly in and out, these hyperechoic marks stay in the same spot. That's an air bronchiogram. This patient ended up having pneumonia, even though their radiographic image looked like a large mass. Same thing here. You see this looks like a large mass here. Looks like cancer. But look how homogeneous this is. There's no hyperechoic border. There's no hyperechoic dots. This patient ended up having pneumonia. Same thing, big large mass over here. But here you can see the difference. Large hyperechoic border, some hyperechoic dots. When you move the probe in and out, these move all over while you're moving out. It ends up being cancer. So some of the, this is pretty new, so some of these studies just came out in the last 5 years, but they're pretty good. Just using these 3 criteria, if you have 2 out of these 3, your positive predictive value for malignancy is almost 90%. And if you have none of these, your negative predictive value for malignancy is about 94%. So pretty good without even biopsying. Not perfect, but it's pretty good. Navigational bronchoscopy, I'm sure you guys have all heard about this now. There's mainly 2 types. There's the electromagnetic and the virtual. I think the electromagnetic right now is taken off because it has better equipment that goes along with it. I think eventually the virtual will probably take off once they improve on some of their equipment. We use it right now primarily to help us locate these peripheral nodules. When I'm explaining to my patients how we're going to get to their nodule, I tell them it's sort of like GPS, that you have in your car, and video game. It tells you turn right here, turn left, go down here. It's actually pretty fun. If some of the fellows I know have done it, enjoyed it. But it can be used for other things. If you're there and you're going to try to stage them, you can also use it to mark your lymph nodes. If you already know they have cancer, you may use it to place fiduciary markers for the cyberknife, for other radiation. Now that we have robotics, with the robotic surgery, they lose the ability to palpate for these small nodules, so we can go in there and mark it with dyes to help them out. Comparing the studies, surgery, obviously you cut out a nodule in surgery, you're going to know whether it's cancer or not. So that's not the issue. The issue is most of these nodules are not cancer. So even in the National Lung Screening Trial, when they looked at high-risk individuals, so these were the people who were smoking, had COPD, out of all the nodules they found in them, 96% were benign. So do you really want to subject all these people to surgery when most of these nodules are going to be benign? Transthoracic needle aspiration, good diagnostic yield, depending on the location. But if it's deeper than a centimeter away from the wall, you're going to have a high risk of pneumothorax, and then your diagnostic yield is going to decrease. Conventional transbronchial biopsy is really poor. Less than 2 centimeters, our diagnostic yield was only 33%. Greater than 2 centimeters, it was still only 62%. Pneumothorax rate was still tolerable, 1 to 6%. But transbronchial biopsies with navigational assistance will increase our yields up to 88%, some of the studies into the 90 percentile. And the highest percent is when you add that radial EVIS onto there to confirm your position, not only to confirm your position, but to hopefully to get in the center of the lesion, which is where your highest diagnostic yields are going to be. And then it helps even lower the risk of pneumothorax. So this is what the virtual bronchoscopy looks like. I think there's only one on the market right now, Bronchus. The nice thing about this software is you can see that it shows you where the vessels are. It labels them for you. You can put other things there. If you wanted to put a node, it would show you where the node was. So pretty nice software. The problem is getting to this area and then staying in that area, and they don't have the support yet for that. This is what the navigational software looks like. So you start your case, you can plan this anywhere. So you could plan this when you're at the office, you can plan it at home. Basically, you put registration points in so that when the patient is in the room and you have the magnetic field created, you can register it very quickly at the beginning. Then you find your spot that you're interested in, you mark it. And it's funny because a lot of people look at this and they're like, that's huge, I could get that. But it's not always about how the size of it, it's where it's located. This is very apical. She did not want an FNA because you'd say, okay, this lady should have an FNA. She had one before on the other lung and they collapsed her lung and she spent 2 weeks in the hospital. So she wasn't going to have that again. But you can see it picks out the path for you once you pick the spot. If you don't like the path it picked, you can pick another path. It's always been right. Every time I pick a path, I've been wrong. But there's a reason. It knows, it knows where it ends. I was convinced one time it wanted me to go through a fissure, and I wasn't going to do it, and I couldn't get in the way I thought I could get in. But this is what it looks like when you're registering. You just go in, you're touching the different areas, and then you can see over here it's starting to pick up the virtual image. And then once it does that, you're going to put these and sync these up so that they match. And then you hit accept, and then you're ready to go. And it'll show you the path. It's pretty easy. So this is your real image, real-time image, your virtual image. You line them up and you follow your path. Now, once you get out there, sometimes you do end up taking different pathways. It looks, I think a lot of times it looks very easy when you're watching. Sometimes it's a little bit more difficult than it looks, because people get carried away with all the different images you can look at. But there's your target. That's where you're trying to get to. It tells you exactly how far away you are to your target. You know, and then once you get it lined up, you can confirm it if you want. Some people don't. You can confirm it under floral. I like to do that just to get a real time. And then you can see here, whoa. Well, in the lower hand corner there was the image of what it looked like under the radial EBUS, and you could actually tell it was cancerous. So fiduciary marker placement is another reason we'd use it. They don't have a software built into it yet, but the virtual does, where it'll tell you exactly where to place these for the radiologist. They have to be separated in space, usually by 2 centimeters and by 20 degrees. That's very hard to do when you don't know where you're at in there. With the software, they can actually tell you where to place it and give you your targets. And then here you can see where we tagged a very small nodule where they were going to do robotics on it, and so they could find it easier. A little bit about photodynamic therapy and brachytherapy, because I think these are the two that are most commonly used to treat early stage cancer. And then sometimes the brachytherapy, when there's no other alternatives left, will also use. There are people out there who will use it for large tumor burdens. I don't. It's hard because you get a lot of sloughing. Patients usually have respiratory distress with it. You have to keep them in the hospital and bronch them usually every day. But PDT, basically what we do, we use a photosensitizer. In the United States, the only one we have is Photoferin, which is back on the market. In Europe, they have a newer one, which is much better. This penetrates about 1 centimeter. The new one penetrates much deeper and has a larger spatial area. For this, when you give them the photosensitizer is going to be taken up and in 48 hours excreted through most of the tissues, except for those that are most rapidly producing cancer cells, but also skin. So they have to stay covered for about 6 weeks afterwards. So they have to wear sunglasses, scarves, gloves. They can't go out in the sun. The newer one, you can inject them the same day you treat them, and then they only have to stay covered for 2 weeks instead of 6 weeks. So this is basically what it looks like. You give them the photosensitizer, they go home, they come back in 48 hours. You take a laser and the navigational or the narrowband imaging. You get your target from the narrowband imaging, and then you use the laser to cause a cytotoxic reaction and kill the cells. If there is a large tumor burden, you're probably going to have to bring them back the next day to clean out the tissue. But if it's something small like this, like a carcinoma in situ, then you just have to bring them back for follow-up surveillance bronchoscopies. This is what the brachytherapy catheter looks like. The same day you place it is the same day they get treated, so they don't have to go home with this. This is what it looks like. You can see the catheter going in. Once we're in there, we look with the narrowband imaging, decide where our points of the beginning are ended. We let the radiologist, the radiation oncologist know, and then they target their area. Just want to go over briefly endobronchial valves, because you're going to be seeing these more commonly. The two major reasons we use these are for prolonged airway leaks and now for treatment of emphysema. For prolonged airway leaks, right now it's only approved by the FDA as a humanitarian use only, and it has to be following surgery. So some sort of lung surgery, either pleurodesis or they had a wedge or lobectomy, and they're not healing. Otherwise, it's not going to get approved by the FDA. The other thing is you should prove that you can stop the air leak with the balloon prior to placing them. So you go in and you find your target of where this is still leaking with the balloon, and then you place these valves. This happens to be the spiration valve. It's a one-way valve, so it doesn't allow air in, but it also doesn't allow secretions out. The endobronchial valves for lung volume reduction surgery, I'm sure you guys heard all the studies when they came out about 5-6 years ago. they did good with some patients, they didn't do good with other patients. So they went back and looked at the data, and they found that the patients who had the best success with them were the patients who had a complete fissure. So most likely they didn't have collateral ventilation. So they went back to the FDA and they said, okay, we're going to target just people who don't have collateral ventilation. And so that's now what the studies are being done, and we're actually involved in those studies and actively recruiting right now. So what are we going to do to show that they don't have collateral ventilation? They are going to be looking at CAT scans, but because we haven't proven that's reliable, they've already checked out a Chartis system, and I'm going to show you that you inflate and you figure that out. The theory behind all this is that you're going to increase or decrease the hyperinflation that they have. Decreasing the hyperinflation is going to improve the mechanics of the diaphragm, the muscles, and improve their exercise tolerance and quality of life. It allows that good lungs to re-expand and fill that area. Also decreases VQ mismatches. So this is what the Chartis system looks like. It's a little balloon here, and it has a little monitor on the end here, and it measures the flow and the pressures. So when you're trying to target your area for these valves, you just put this in, you watch over here on the monitor. It takes about 3 to 5 minutes, and you should see the flows going down if there's no collateral ventilation. If they still have collateral ventilation, which a lot of people do, then they're not put in the study. This is what the valves look like. You can see here, it's a nice picture. This is when the patient's expiring. It opens up and it allows air and secretions to come out. They're taking a breath in over here, and it closes so the air can't get in. They are removable. You end up targeting one lobe. So you try to find one lobe. If you collapse that one lobe, they don't have collateral circulation. We're not doing more than one lobe at this time. And also they're not targeting right now big bullae, which is what most people expect. They're like, oh, I got someone with a big bullae. Can you collapse that? And that will probably be something they do in the future, but right now they're not enrolling them because what happens is they usually end up getting a large pneumo, which is a good thing. Those patients in the studies did the best because you're accomplishing what you need to accomplish. So they're targeting one lobe and trying to do it a little bit slower. Bronchial thermoplasty, which we now have here also. We've probably done about 20 patients now. But when you look at how many people suffer from severe asthma, we're not doing a good job of getting people the adequate treatment they need. Data from 2009, 9 patients every day dying of asthma in the ER. Last fall, we lost 3 people at St. Mary's in the ER from asthma attacks. So this is not a benign disease. A lot of people blow it off. People die every day from this, and we're not doing anything. This is the only FDA-approved non-pharmacological treatment for asthma. It's right now approved only for adults and only for people with severe asthma. If you look at how many people in 2009 suffered from asthma, approximately 2 million of those had severe asthma. So that's a lot of patients, and you're considering we've only treated 20 patients. We're doing a pretty poor job. So basically what we're doing with bronchial thermoplasty is after time, these people have constriction, relaxation, just like any other muscle, it becomes hypertrophied. It's not bad if you're lifting weights and that's your bicep, but in the airway, that's bad. You got a much smaller airway now. And then it doesn't take much to trigger and cut off this airway. With the heat that we apply to the airway, reduce the smooth muscle back down to normal size or close to normal size. That we understand, but then also these patients are not as hyperreactive. That part we don't know how that came about, but it's a good side effect. So this little video clip here is a canine model, and what we did is we treated this lung, and we didn't treat this segment. This segment, and then we're going to inject methacholine into both, and then you can see afterwards how they look. The one on the left is the one we treated, and it stays wide open, and this one collapses back down. And this is the probe. So we heat it up to about 149 degrees, which is the temperature of a cup of warm coffee. A lot of people are like, well, how are you going to target, all that area? It's a lot of area to target. This goes down to 3 millimeters and as high as 10 millimeters. They're going to come out with one that goes as high as 14 millimeters. So 3 millimeters to 10 millimeters covers about 75% of your airway resistance. So you're getting a lot of the area covered. So the studies on this were very good. It, by some people's standards, was probably one of the best sham studies done on a new device. So what they did was they subjected both the control group and the treatment group to the bronchial thermoplasty as far as they got put under sedation. The probe went in. The doctor hit the pedal. You heard the same sound that you hear when you're getting the heat. It's just that some of them got heat and some of them didn't get heat. And the doctors were blinded to who got it and who didn't, to take out the placebo effect. And you can see, compared to the people who got the sham, there was a 32% reduction in severe exacerbations, 84% in ER visits, 73% in hospitalizations, and 66% in days lost from work or school. So really good results. Is it perfect? No. So there's still what, 16% who didn't have any response. We still don't know why. And I'm sure part of this goes back to we still don't know how to subtype asthma. There's more than one type of asthma. Just like African American females die the most from asthma, they've isolated 3 genes now in the African Americans for asthma. So we still don't know, and we don't have a good marker on who's going to respond to bronchial thermoplasty and who's not going to respond. So that's why it's just approved for people with severe asthma. It's very safe, so most people with severe asthma are just do it. I don't care, do it. I want to try something, I'll try anything. Few of the other things I don't want to really dive into, but just to remind you that we can offer your patients whole lung lavage for PAP. You don't see PAP too much, but people who have pulmonary alveolar proteinosis benefit a lot from whole lung lavage. We do transtracheal oxygen. That's this over here. So these are mainly done for people who, vanity purposes, who don't want people to see the oxygen they're wearing, they cover it up, or for people who want to stay active prior to maybe transplant and they're on high flows. This allows you to decrease the flow that they're getting, or they're just not tolerating all that high flow through the nose. Pleurex catheters, recurrent malignant effusions, we do that. We've been doing that a lot here, but still I think some people forget that you can consult us for that. And then the bedside trachs. And I'm sure I've missed a lot more things we can do, but I was just trying to hit on some of the more common things. These are some of the things on the horizon. We don't have any of these here. I'm not sure if their place here is going to stay. There's a few I'm going to go over that I do. The OCT is very similar. You can see the picture here. Very similar images to what you get with ultrasound. Instead of using sound waves, you're using light waves. I don't really think this is going to go much anywhere. The endomicroscopy is pretty cool. There's a few doctors close to here in Indiana that have this. They've come out with a new generation, so hopefully it's a little bit better. But right now you have to do special stains to get better images. But you can see with the special stains macrophages and things like that. But right now what they're doing is using it to look at the architecture of the airway so you can see the alveoli. If you're going to be doing cryobiopsy in someone with diffuse interstitial lung disease, this would be one of the ways you might target the area that you're going to go to. You look for the area that's most destroyed and then go there and biopsy those areas. So this one I'm still on the fence with. I don't know. I'm going to wait and see what their next generation looks like. But where I think more of the data is showing to be promising is in laser therapy again, different type of laser therapy. Basically, there's a lot of people looking at using Raman laser to look at the way the molecules in the cells change with cancer when you shoot laser at them. So this is not like a vaporizing laser. This is just for the light. And just recently at the European Congress, Henry Ford presented their paper, and their diagnostic yields were up to the 90 percentile. There is one on the market right now for GI, and there's one being marketed for pulmonary, and their diagnostic yields range anywhere from 70 to 90%. I think part of it is just going to be getting more patients in to collect the data to see, get more knowledgeable about the changes. So this is what normal in the airway would look like. And then when you look here, this is hard to tell because it's not colored, but you're going to see the changes in the way the molecules respond to the laser based on whether they have cancer. So they're not only just saying, okay, this person has cancer, but they can tell you whether this is adenocarcinoma or whether this is small cell or squamous cell. There is a doctor now at the Laser Institute in Tennessee that has developed a laser now that will do that. Then he can switch it to another with just a flip of the switch, and then it's going to vaporize the tumor. So you take this probe out, you go out to the pulmonary nodule that's very distal, turn this on, yes, it's cancer, flip it to another, and vaporize it. So it'd be interesting to see. Just a little bit about some of our challenges, I think. One is innovation, which I think we're right in that time period now where it's actually our time now, not GI's time. Sorry. But, for years we've been using GI sloppy, leftovers. And now people are actually developing stuff for us, which is nice because it is different than the GI tract. The training and the quality assurance, which I think is big. Right now there's big controversy. There's some people who are like, no, we don't want to get ACGM certified. We don't want board certification. Just let us do what we're going to do. And I can understand why they want to do that. When they went through training, they did it on their own. They're more than capable of doing it. But I think in this day and age, you got to have safety should be number one. And there's just too many people out there, especially some of the reps, who will push, oh no, you can do this, this is safe, just do it, and we end up having disasters, and we end up seeing them, and so I think it's very important. What we're doing right now is this is going to be the first, December of this year is going to be the first year that we're having board certifications, so that all the people who have already been trained can go ahead and grandfather in, and then we can start training our fellows. This is a big issue for us. You could see a lot of my lecture today was a lot of fluff, not a lot of substance. And part of that is because a lot of our studies are just small case reports. We got to start working as a group and collaborate on our studies so we can get more research. And then reimbursement. At least 10 years ago when I was going into fellowship, everyone was going into GI. GI was good reimbursement. Our reimbursement still sucks. But part of that is because we haven't shown the research, and we haven't developed any center of excellence. So this is something we're working on currently right now. We actually started this year our first IP fellow. I think Dr. Mustaf is here. So we do have a fellow. If you have any questions, any consults, just dial ULP IP. Dr. Guhar, who's here, I don't know if he wants to stand. He's one of our new IP docs. He's going to be doing stuff here, but also mainly developing the IP program at the VA. And I actually think he's gotten a lot of his equipment now, so he's up and running. And then this is just our team, so if there's any questions, I can take any questions.
The number is 421.
421, oh yeah, that's right. So if you're not dialing from inside, it's 421 ULIP. Thanks.
Oh, thanks, Tanya. That was exciting, and it was a lot, and actually a lot that I had never even heard of before. So that made it, very interesting for me. I'd like to start off with one question, and it relates to, quite frankly, your last slide. How much of this can somebody learn in a year?
Actually, a lot. So the actual techniques are not, I don't think, that difficult. I think it's more about the workup before you're actually deciding to do the procedure. So I think a year is pretty good. Some people argue that they could do it in 8 or 10 months. We're going to try to make it a year accreditation.
Okay. Questions? Julio.
We have this traditional approach, the basic pneumonia, and then you have to follow the clinic to see the pulmonary result 1 or 2 months to see the suspicion, then something is left, then maybe cancer. What you're suggesting is that then to see if the combination of cancer plus pneumonia is so common. At the moment that the basic pneumonia, you can figure out right there this pneumonia is in combination with cancer.
It's hard. So it's very hard, yeah. Because, the inflammatory cells, when you have the pneumonia there, can interfere with the pathologist's diagnosis on a slide.
When you say the ultrasound,
But the ultrasound can help. So there have been a lot of instances where we've had that issue where someone had a pneumonia, it didn't go away, they sent them to me, it's weeks later. You already know most commonly it's going to end up being COP. But if someone's at high risk, I will do a bronchoscopy and look with the ultrasound. And most of the time we're right, just by looking with the ultrasound. And then I feel more comfortable waiting. Or vice versa, it looks very suspicious, and then I'll go ahead and biopsy it. Yes?
Thanks for the presentation. It's very interesting. It seems that nowadays most pulmonary fellows get exposed to bronchoscopy to some degree. Are these other tools such as optical imaging or differentiation of tissue, do you think that's something that ought to permeate into the 3-year fellowship so that you've got more people out there doing the initial bronchoscopy that can then differentiate these things? Or do you think that's going to gravitate more towards this credentialing issue and having a certified IP specialist?
So yeah, I mean, this is like we have debates about this for hours. My personal opinion is I think it needs to be something with extra training. It's hard to recognize patterns like that without seeing it over and over and over. But you're right, the whole definition of interventional pulmonologist, I mean, by definition, interventional pulmonologist is anyone who can pick up a bronchoscope and do something. So yeah, it's leaned more towards procedures that are a little bit more complicated, that takes a little bit of extra training. I think the problem is that, yeah, there are some people out there who don't need a whole year that are going to pick it up very quickly. But the problem is that that's not the majority of people. And I'm sure you see when you get your fellows in, some of them just don't have that hand-eye coordination. It takes them a little bit longer. Or the pattern recognition, or actually the skills to work the patient up. Do they really need this? Don't they? In my personal opinion, for safety, yes. I was going to put up some bad slides, but I didn't want to end on, okay, this is all the bad stuff if you're not trained, because there are a lot of the companies that will push people. They don't care if you're trained or not. And so I'm the one stuck picking out the stents that were put in wrong, or I'm the one, stuck, fixing whatever they did because someone told them, oh, it's easy, just put this stent in here or just balloon this, and they end up tearing the airway. And so I personally lean towards, I think it should be an extra year training.
Second question, you mentioned desensitization in the reactive airway disease, methacholine challenge. It'd be interesting to know, could you demonstrate that with like Pepsin or something? Because the difficulty we have is differentiating reactive airway from GERD. And even if it is thermoplasty still helpful in that population?
Yeah, so you...
Like having to undergo an empiric fundoplication
to
treat weakly acid or non-acid reflux.
I definitely think we need to collaborate on something like that, because what he's trying to say is, I get referred a ton of severe asthma patients, and I do an extensive workup before I subject them to the bronchial thermoplasty, because many of them may not have severe asthma or asthma at all. They have bad reflux and they have reactive airways. Now, some of them may have asthma and reactive airways both, so it's very hard to differentiate. And so a lot of times I'm sending patients to them saying, fix their reactive airways before I do bronchial thermoplasty. In part, that's me, but in part, it's also driven by the insurance companies. They don't want to pay for something that may be just reactive airways. I think I've been duped maybe twice, thinking someone had asthma. And like I said, I do a very extensive workup, CAT scans, bronchial barium swallows, but I've still been fooled, because sometimes you're like, okay, same thing with vocal cord dysfunction. You get a lot of these young females who have paradoxical vocal cords. Does that mean they don't have asthma, or is the asthma triggering that? It's hard to differentiate. And I actually started someone and never completed them, because I thought after I started them, no, I think this was more the vocal cord. Chip?
You mentioned eye-hand coordination. I noticed in a lot of videos this I see tend to be jerky, kind of back and forward kind of stuff. Robotic bronchoscopy or computer-assisted navigation? You showed the direction, but what about actual control-driven kind of stuff?
As far as?
Computer driving it.
Oh, the computer doing it. I hope not. I don't know, Mayor, what do you think about that? I hope not, but some of the procedures we do, I'm not going to lie, are very easy. Like bronchial thermoplasty is very boring, but you still have to pay attention. You got to know where you are in the airway. You got to know where you've pulled to. You don't want to overlap and retreat the same area. You don't want to skip areas and do the patient a disservice. But I haven't seen or heard of any robots for us yet. I'm sure they're gonna come up with something. I don't know.
Any other questions?
I'm just curious, the laser fracturing for the stents?
Yeah.
You think you're able to control the depth of the penetration of the lasers?
Yeah, so I took it for the metal. I usually will take it up to 100 watts. For vaporizing tissue, we'll usually do 40 watts. But it does have an aiming beam on it. So I set the aiming beam right on it. We have them paralyzed, and then we stop ventilation. And it takes only about, you saw, it takes like 2 seconds and it will fracture. But you're right, if you miss it, you could definitely perforate the airway wall.
Okay, any other questions?
Okay,
Thanks,
thanks.
Tanya.
Thank you.